Thank you so much for joining us for this topic that is near and dear to my heart. I am definitely honored and in awe of the amount of participants that are taking this class with us today. I also want to reach out to everyone and say thank you so much for joining, and also to stay safe. I'm glad that we're able to do this each from our own houses. A couple of quick housekeeping disclosures. I do receive a fee for speaking at today's educational activity. I do not maintain any financial interest in any of the products shown in today's lecture. I am employed as a pediatric laser instructor and trainer, and I serve as a clinical consultant to BioLase. But all the clinical opinions, techniques, and technology presented in this course are my own and do not reflect that of any organization or commercial enterprise. This afternoon, the learning objectives will be that at the end of the webinar, the participant will be able to discuss the benefits of laser technology for pediatric patients, to understand why frenectomy should be a routine procedure in a dental practice, and to verbalize how a frenectomy is performed safely with the laser in the dental office. It is interesting there's about 1.2 million dentists in developed countries worldwide. But out of these, less than 10% use an all-tissue laser. So that's approximately 100,000 dentists. In comparison to the 100,000 dentists who use an all-tissue laser, we have 700 million users of the iPhone. And so it makes us wonder, what is it about the laser still that people are not seeing the value in it to be used in their dental practices, especially in the pediatric realm? So in doing some research, the top 3 reasons why we see dentists are not using lasers are the following. The cost, because it is definitely more expensive than a high-speed rotary. The speed, and I do put a little asterisk there, because the speed does increase when you are experienced with the laser product and the laser technology. But on a one-to-one basis, we are still taking a little more time for each prep. And I'd like to share later how this doesn't necessarily make you less efficient. It just, if it was timed, that's where the speed differs. Last but not least on these top 3 is training. The training use of a high-speed rotary is done in dental school and perfected in practice, and it becomes quite familiar. But the training for lasers is a little more extensive. Additional training is required and should be done to make sure you're getting the most out of your laser and also doing the best possible work for your patients. Another thing that could be listed on this chart is that most dentists are very comfortable doing the same procedures most of the time. And many do not want to step out of their comfort zone to learn something else in which they might feel very uncomfortable. But I do encourage that we step out of our box because we can offer some great things to our patients. There are also that choose not to use the laser. First, I discuss is that some people say that lasers cannot be used on patients when there is metal in the mouth, such as fillings or appliances. This is actually false. Firing reflective surfaces should be avoided. One can perform conditions that call us.
Hi, Dr. Murzyn.
Right.
Just a bit of feedback, and so we're curious about bandwidth, and maybe if you just turn off your video camera, that will improve the bandwidth for all of the attendees, and your audio might improve.
Okay. Is everything else, the speed going fine? Or?
Yes, absolutely. We're just getting, you're just breaking up a bit, and so to enable everyone to better hear you, if you turn off your camera, that'll free up some bandwidth, and we'll turn you back on for Q&A. How about that?
Sounds great.
Excellent. Sorry for the interruption.
Thank you, everyone, and I apologize for that interruption. The second myth that I'd like to discuss is that people often admit or say that hard lasers will injure tooth pulp. Again, this is false. Because lasers that use water actually raise the pulp temperature than the high-speed piece use water. Next, some say lasers are not particularly safe to use on young patients unless they are sedated to prevent any movement, or else there might be soft tissue trauma. I will argue that lasers are safe to use in the operatory environment, and ablation can be stopped easier than the rotation of a high-speed handpiece if unsuspected movement happens. Lastly, and this is a favorite of mine, in every training that I go to, many doctors say, I cannot live without my nitrous oxide, and so I cannot use a laser because lasers would be able to be combustible. And is actually, with proper evacuation and precaution, nitrous can be used with laser to increase the patient comfort and assist you with your behavior guidance. The American National Standards Institute actually has a statement on this, and it really supports that we still can use this as long as we take the proper precautions. So then, why do we use laser? Well, we have to admit it's kind of cool. It's a fun toy. And many people, many adults who bring their children in, think of laser like it was mentioned in Austin Powers, our laser. And it is kind of fun to think about this new and different technology. But why else do we use lasers? Yes, there is the wow effect, but we actually have a lot more benefits to our patients and to ourselves and our staff that we can provide with the use of the laser. In particular, I want to consider some pediatric treatment considerations because we are working with a different set of individuals. These individuals sometimes have the inability to localize or differentiate pain. So even though they've had their tooth anesthetized, they're going to still consider that painful because that is their perception. And they may not know where that's coming from, but they're just having an awful time with the situation if they're not able to differentiate that. Time is definitely of the essence. We have to work quickly. And we need to get a lot done at one time. Kids are taken out of school, parents are missing work. We don't have a lot of time with behavior being of an issue sometimes with a younger population. And given that behavior, sometimes some guidance is needed. And so we have to be able to work under the constraints that we have. But I always remember that we can shape their dental and medical future by giving them a different association of dentistry. Not to think about what their big brother told them about the shot that they are getting, or not being told by their parents that it's not going to hurt that bad. We can make them want to come back and, and ask for treatment in a certain way and know that they don't have to be worried about that and to trust us. And of course, we have to interact with not only the patient, but also the parent and the guardian. They're watching you. That's their baby that you're talking to and that you're treating. And they feel very protective against that patient. So we have to realize that, and we're talking to them too and trying to please them and make their experience with their child very, very good. So then what we think of, or many people think of when they go to the dentist, is that they have a big fear about going. And why? Because they expect pain, and that makes them very anxious. But we really want to take these away. We really want to make sure that they can come to the dentist and trust in us and have a better experience. It's not like going to Disneyland, but we can definitely make it much more positive for our patients. So that's why I put that down as my number one reason why pedo needs an all-tissue laser. It is for that improved patient experience. So they can come in and they can have a smile like this, not cowering behind mom or dad's leg, not saying, I don't want to do this, not, going with all those things that were said to them about, well, this is going to happen, that's going to happen, and you're going to hurt me. We don't want that to be their experience. We want it to be so much better. So we can definitely offer patient comfort, less shots. I don't want to have you go away from this saying no shots. There are some times where we do need some local anesthetic in the traditional way, but we definitely do make it less uncomfortable, and we have a different way of approaching it if we can many times use the laser technology to be able to offer shot-less dentistry. We also can be efficient. I alluded to this before. It's not that I can cut a prep that much quicker than with my high speed, but I can certainly get a lot more done in a certain frame of time because I do not have to worry about anesthetic maximums. I do not have to worry about that anesthetic setting in. I do not have to worry about the overdose and of other medications that might be used with it. So I can get more done at the same time. I can also get more done because I can use the laser, as we will see, in different ways on the same patient to actually quicken the treatment that they would normally have to wait for. A good example is we would like to seal teeth. And if a tooth is non-erupted or only partially erupted, it might be a little bit difficult to seal that tooth because of the isolation. But with the laser, we can do a simple uncovery and then seal the tooth in the same visit, not having to have them come back or wait. Behavior guidance. This is something that I never thought would be an advantage of my laser, but it certainly is. As I talked about earlier, I want to give the kids a different association of dentistry. I don't want them to fear coming in, and I don't want them to have to postpone treatment because they're afraid to do so. And I don't want to lead that to other bad behaviors because now they're in pain and even more scared. So we can use this as a choice that they have to get their dentistry done. And from doing that, we have a positive association, not only at this visit, but towards future dentistry, and gives them less anxiety, not only at the current visit, but at future visits. And also, we can avoid unnecessary sedation and general anesthesia for those kids that don't have an extensive amount of treatment, but that we want to take care of quickly and easily. We can still do that in a clinical setting, which has a lot of benefits for not only the patient, but the parents as well. So we definitely want the kids to have a happy experience. And so when we talk about a rating scale, where would my patients like, where are they at when they come into the visit and where are they at the end of the visit? And we would really love to get the 0 on this. This is the one time where we like a 0 score, that there's no hurting. And if asked that when they came back again, what procedure or how would they like the procedure done, that they would always pick the laser. And in the many years that I've been doing this, I think I had only one patient that ever said, yeah, I kind of like the numbness feeling and I'd kind of like to come back and do that again. But the majority is definitely in the camp of, I love the laser and I want to come back. So I did a little something fun with my laser. I renamed it. And I'm getting a lot of mileage out of this name with the advent of the second Frozen movie. This is Elsa. I decided to make an acronym and not just call it, you know, by the name of the laser itself. And other people have other wonderful names, but this is why I decided to call mine Elsa. This is my erbium laser for specialty application. Nerd that I am. Didn't take that long to think of this, but this has been fun. My patients can ask for Elsa to do their treatment. We go a long way to prepare the child to know what's coming up next with our usual tell, show, do methods. And this way we can talk about how Elsa Magic will actually be spraying on the tooth, and it'll be cold, and it'll make some noise, and it'll make them feel a little bit different. But this is certainly a different association than the pain that they were expecting with a traditional anesthesia shot. So now this brings us to my second reason for pedo needing an all tissue laser. And it kind of comes from the first reason. We can be happy about what we're doing. And it not only makes us have happy patients, but it makes us happy. So happy patients and guardians mean return patients if we have that good patient experience. If we do, we get some referrals and good reviews. That means that we get new patients. We can set our practice apart. We can have search optimization on Google and other. And then that leads to us really enjoying this. We get to see more patients. We're doing a great service. We're actually even having a little fun with it. It's a cool toy. And then we do get some profits from this and a good return on investment, because it is an investment. Next, I want to talk about how this is giving us a high standard of care and service. Not only because it is good technology, but it is what people are asking for. They are researching this. They are seeing this online. They are seeing their friends get treatments done with laser, and they want that for themselves and especially more for their child. And so if we can offer this to them, they're going to come. They're going to want to do this. It's really cool when somebody really lets you stand out and say, hey, my dentist rocks. Why? Well, one of the reasons can be that I'm offering this really good new technology for them. I want the best for them. Don't we do that in all our other products? Don't we want the latest and greatest and the safest for our patients? So that's why I like to offer this. But the laser is superior in so many areas. And so I've listed these out for you. The reason why we can take care of the patients in the best way. We can have our work be high quality. We can be very preventative for the future. We can avoid other types of treatment that we wouldn't want to, AKA having to cauterize the area or use some other medications. And it can be safe, and that's a big thing for me, to have this be safe for my patients. And erbium laser technology is wonderful because it is kinder and gentler to the surrounding tissues. When we used to use an electrosurgical unit, we were damaging about 1,000 to 1,500 cell layers. And even with a scalpel, it's still significant. But with erbium technology, we're only affecting a smaller range, about 5 to 10 cell layers. So this makes a lot of sense when we're talking about how this area heals. And so we have a lot quicker healing and a lot less post-operative sensitivity because of the area that was affected. My number 4 reason for pedo needing all tissue lasers is minimally invasive dentistry. I want to preserve tooth structure. I don't want to go with the old way of GV black extension for prevention. Also don't want to create additional damage to the tooth. Sometimes the friction and heat of a high-speed handpiece can cause microfracture and sensitivity that way. I'm also thinking about prevention, preventing this tooth from going down the path of needing bigger and bigger restorations or even having to be taken out. So we would like to keep this to a minimum. And then there's also less need for medicaments and chemicals. And where this most comes into play for me is in my treatments of pulpotomies. Definitely a benefit when doing the treatment with a laser gives us less pain. It can reduce the anxiety in the patients to do such an important, intricate procedure. Minimizes the bleeding. In a pulpotomy, we can use this to coagulate instead of using another medicament. This can, at the same time as it's causing the coagulation, can also reduce the bacterial load because it sterilizes the area. And once again, we can preserve more healthy tooth during this cavity treatment and pulpotomies.
Hello, Dr. Murzyn. We're just checking on the audio. I apologize. It seems that Dr. Murzyn has lost her internet connection for a moment. So I'll ask everyone online to just be patient as she logs back in, and we'll get her teed up again just as soon as possible. As you know, many companies are offering webinars in previous to live education. And so with thousands of people online at the same time in any one presentation, sometimes the bandwidth suffers, and presently we're well over 1,000 people watching this. Certainly appreciate your patience as we get her back online.
Hello?
Yes, we can hear you now. Thank you.
I don't know, it just kicked me out and said done, but
No problem. We were having a great time just waiting for you to come back, but please take it away, doctor.
okay, thank you so much, everyone. I lost my video now.
Yes, and so we're seeing the advantage of this slide, if that helps you.
Yeah, it's not letting me advance.
Okay.
Just, lost all my.
Sure.
Here's my PowerPoint, and
if you stop sharing the screen, Dr. Murzyn, and then start over again, it should restart.
Apologize for the disruption. Everyone, we'll be back with you in just a moment. And again, thanks everyone for their patience. We'll be bringing it back up just as soon as we can. Looks like we're almost there. Yeah, it looked like you were at slide 27, doctor.
Yeah, and I'm just gonna have to read it from like not the.
Sure, whatever you feel most comfortable with, or you can just hit the full screen slide icon and it should come back.
Now I've lost my Zoom page that it shows me, the meeting controls I don't have.
Okay. If you can go to some full screen view, everyone else can see it. We can see your presentation in slide sorter mode at the moment.
Yeah, I'm trying to get it, and I don't know what this slide share thing, redirect.
Perhaps at the bottom there,
Yeah.
or click on slideshow and that should bring us
There we
back.
go.
There you go.
There we go.
Hopefully it advances.
Okay. Nope.
Okay.
Okay, let me try something else. Okay, let's see.
Sure. And if not, because we can see the slide sorter view, you could probably speak to them from that. It's certainly better than not being able to see anything.
Okay, I'm not going to use the mouse anymore. That seemed to be giving me the problem.
Okay.
And so I'm back on here with, I'm just going to advance it by myself.
Yeah.
Okay.
No.
Thank you everyone again. I apologize for that interruption. Here's a look at a pulpotomy and the conservative nature of it with the use of a laser. Okay, moving on to our fifth point, it's adding procedures and keeping procedures in-house. I'm sure so many of you have read this book cover to cover, right? Okay, not, but we know that there are many procedures that are under our scope and we would love to do them. Some of us have done procedures all through dental school and residency that we're comfortable with. Others would like to do some other additional procedures. And I'm here to share with you some of those additional ones that I think are very well accepted and to be done by a dentist, and we can move forward on that with some additional training, but that a laser can be very, very helpful with. So yes, you can do good treatment for your patients with these additional procedures. And with just these additional procedures alone, there's a great return on investment and a great, great service that we can offer our patients. Take care of aphthous ulcers and herpetic lesions on a daily basis. When I first started doing laser treatments, I actually were taking care of more of my residents and my team than I was of patients. But what a great marketing tool that was. They were great testimonies to how this laser could work on something like that. They had suffered with this, many times, and I was able to help them right on the spot, and then I was able to help my patients as well. So that's a simple procedure that you can add to your repertoire and be able to help your patients. Another one is expose and bond, done in the orthodontic realm. You don't have to send the patient away and then wait for that tooth to erupt. We don't have to send them to another provider so that they can expose that tooth, and the orthodontist that either works with you in your office or that you send to can actually get their treatment done more quickly as well. Lesion removals, and this might be a different comfort level for everybody, but I do see a lot of mucosal patients in my practice. I do see a lot of just irritation fibromas, and I'm able to, at the same time as I'm taking care of other treatment, again going back to the efficiency of this, remove those areas that are giving them a problem, and it's a great service to them, and they don't have to wait, and they don't have to go elsewhere for this. And then close to my heart, doing frenectomies. This is, again, another day-to-day thing that I do, and it's a great, great service that I can help my patients with. So I'd like to spend a little more time talking about frenectomies and how a dentist is adequately prepared to take care of both the infant and the older child with a tongue tie or lip tie, and be able to do this safely and easily in the office setting. A couple pictures here of what I mentioned at the bond, and here's the mucus seal. And to make up for time, that's why I'm skipping ahead. So there's lots of discussions that can be had about frenectomies. Not everything that can be covered today about why we do the frenectomies and how we screen for frenectomies and kind of some of the steps that go on. I'm going to share some of them, but I know that there might be a lot of questions that might come on Friday about even just the getting into frenectomies portion of it. But I'd like to share a few things. So how do we decide? Well, definitely we want to have somebody come in that has a history suggestive of tongue tie contributing to breastfeeding problems. Not just because the mom, read something online or their next door neighbor had this done. So we definitely want, some way that how it was affecting them. We want some history of that. We need to do a good oral evaluation that shows us that the problem is consistent with a tongue tie or lip tie. And we want to make sure they have appropriate lactation support and intervention beforehand. And then we want to check for ongoing infant and maternal symptoms. If things are, improving, if things are being helped by other means, I'm not just willing to go in there and be cut happy. My residents, my colleagues have always heard me say that I need to make sure that I can give the family a predictable benefit about doing this procedure. And I'm also not one of those people who believe that relieving a tongue tie is going to cure everything from acne to Zika virus, and certainly not the coronavirus now. But I know it can help in so many ways. And so I look at it thoroughly and thoughtfully to make sure that what I'm doing is the right thing for this family. So the things we look at for infant factors, and this is not an exhaustive list, but we're looking at their latch, they're looking at sounds, we're looking at how their feedings are going. And certainly a lot of patients in the infant realm come into me with problems with poor weight gain. And we definitely want to address problems related to that. There are also maternal factors. And so sometimes the patient will come in, the baby will have known factors, but mom's having a really difficult time. And we still want to help this breastfeeding dyad. We still want to help make the situation better for the mom and baby. And so if we do decide that we need to help this infant, what other things are we thinking about in the future for this patient that if we did not address this because of the breastfeeding problem, what other things might be preventing in the future? Well, again, it's not every single case, but these are some things that we are considering: speech problems, the jaw development, and jaw development leading to other things like malocclusion and muscle imbalance. We have also seen where patients will have an obstructed airway, abnormal oral movements, so therefore they're not really processing the food in their mouth correctly for chewing and then swallowing. So they're having a difficulty with swallowing. And then from a dental perspective, the increased caries risk due to the inability to access the areas to brush or to clear the food. And because the tongue tie and lip tie can affect the dental and jaw development, as I mentioned, laser and tongue tie lip release can have a benefit on all the following things. And maybe it's not all that each patient needs, maybe it's some, but these are the things that we're looking at for the future. And I do think dentists should be doing frenectomies. We know that dental implications of tethered tissues, and we'll evaluate the case thoroughly, both for the immediate and the future predictable benefits that we just went over briefly. We're experts on the anatomy of the oral structure. We're used to working in mouths and with all the isolation issues that we're used to. And we also do it in a clinic setting. We don't necessarily need to take this baby under general anesthesia or under some kind of sedation. We can offer comprehensive treatment and continuity of care, not just that they go in for the frenectomy treatment and then they don't know where to go from there and the other needs are not being met, so we can meet those. We're equipped to manage the occasional complications of the treatment, aka there's some bleeding. It can be beneficial to our practices. Okay, we can have practice growth and we can make a profit on this. That's not why I do it, but it is a beneficial thing to our practice. And last but not least, and certainly high on my list, even though it's the last one on this particular list, is that we can provide a wonderful service to our patients that can impact their lives. So here's a little testimonial that I did include from a patient of mine who went from, if any of those of you out there are mothers and have had difficulties, this is a lot, the triple feed of nursing and then bottle feeding and then pumping, and it takes up all their day. It really changed this particular patient's or family's life. And this is not the one and only letter I've received like this. This is one of many that we can help. So I want people to know that I don't just jump into this. I do want to be thoughtful and thorough about it. So when a patient comes in and their family comes in, I do a history and a thorough exam. Sometimes there are therapies that I'll recommend, whether it be still working with a lactation consultant or in an older child working with a speech therapist, a feeding specialist, etc., to help the child in other ways. And when that therapist also thinks that we've reached a plateau, that we really can't achieve any more of their therapies, then I will also be able to help in my way of doing the treatment. And during that treatment time, whether that be the same day or it's postponed a little bit to get those therapies, I definitely want to make sure we discuss expectations fully. Let the patient ask and the parent ask questions. Make sure that we know that there's an aftercare, that there are things to be done. It's not just an instantaneous fix, that we have other therapies that might be considered. And then I do this treatment only by laser now, not using any other method, because I can not only do the surgical part, but I can also offer low-level laser therapy for the comfort and healing for that surgical site. Then about 2 weeks, and even it can extend a lot longer, there are continuation of exercises, there's some aftercare. We may refer if they're not already set up with somebody for other therapies. And then we want to return to the therapies that they were already doing. And so this is the whole treatment sequence. It's not just drive-by dentistry that they come in and they, just pop in my chair and do this. I am probably known for the fact that I don't treat every patient that comes to the door. I want to make sure that I can, again, give them a predictable benefit. So what does the procedure itself look like? Now, I'm going to show you some pictures of the way that I do it and some armamentarium that I use. And I know others are using something different, and they're, to each his own. I just want to provide some examples and some suggestions. Some of these are based on absolute safety. I mean, we definitely want to make sure that we protect the eyes. We do need proper eye protection for the infants and the parents and the providers. Shown here on the slide is a pair of goggles that we use for infants that fit a lot better than a normal set of goggles that come with the laser. On the left side, there is a picture of another set of goggles that could be used for the baby, as well as a swaddling. We use this on some of our infants when the parents do say that they are much more comfortable with that. but not necessarily every child. And last but not least, a mouth prop, different kinds, different sizes. Not everybody needs this. I can often, position the baby's mouth open, but if there's an older child with teeth, then we might be using one of these. And again, proper eyewear for everybody involved. Here's something called a groove tongue director. It can be used for other reasons too, but this is very, very helpful, and we'll see in a future picture how it is positioned to best access the area that we're working on, and to really assure the parents that what we're working on is the frenulum and not necessarily taking care, tissue out of the tongue proper or the floor of the mouth or something else. So we'll show that in another picture. But here is what I use for a topical anesthetic. It is a compounded topical and quite profound in these areas. For an older patient, yes, I might still use traditional local anesthetic, but for the infants, I am using this and I apply it with a microbrush. This is a slide showing what I use for the Waterlays product, and I just wanted to point it out about I'm using some different tips that might be a little more tapered, the ones like a chisel, some ideas about what we're going to use as a surgical tool, this is for the Waterlays specific. And here's a couple more of those tips if people were kind of curious about what I use in the Waterlays. And here is a picture of that tissue being removed. I wanted you to see that it was not particularly in contact. We're touching it a little bit, and there's some movement back and forth. It's constant movement. It's not just tearing the tissue. So I wanted you to see that it wasn't tearing tissue with that. And here's a picture looking at how the energy is delivered and absorbed into the tissue to be able to ablate. And again, not intending to drag the tip of the laser on the tissue just to cut it that way. But I'm going to suggest this approach. This has worked very, very well for me and for others that I have trained, to think about opening up this area and not just clipping it as we used to do. So the arrow is indicating that we're going from the base of the tongue down towards where the attachment is, whether it be the floor of the mouth or behind the lower ridge, that we're moving in that direction to separate the tissues that way, and actually getting a feel for the tissue quality and how well it is removed, because different biotypes are going to remove quite differently, and different attachments are as well. But I did want to point out that this is the direction, instead of starting at the floor of the mouth or at the ridge, even if there was some webbing there. Second set, we're opening it up a little bit, and then we can now see that diamond shape that we are trying to achieve. And lastly, making some horizontal cuts so that we open up that area on the floor of the mouth, actually. So here's a clinical case, and this is a patient who was 4 at the time, difficulty with speech. You can see the depression of the tongue. You can see when he tries to lift his tongue, that restriction there. And here's that groove tongue director being used so that we can, show it to the parents. We can access it for our treatment. And the way that I would be doing the ablation is in this direction, as I described in the previous pictures. And here's the after. So this was a case that wasn't that, extensive. And so the immediate post-op picture is showing that there's not much of a big diamond shape defect there or wound, but still that the release is quite effective, that he can, now not have that depression in his tongue and move his tongue quite readily. Here are some shots of a baby, same type of thing, using the groove tongue director. I would be moving in that downward direction. Here's a look at treatment that I usually do in a lap-to-lap position for infants. Here's immediately afterwards with minimal bleeding and that diamond shape. And here's a look at the difference when there's a thicker frenum and what the aftermath might look at a little bit differently. Okay, here is the wound that we talked to the parents about beforehand, letting them know that it'll look like this, because I don't want them to think that this is, you know, an infection or pus or thrush or anything of those sorts. So we do talk about this and show them pictures. And here's a little bit of example of how we're having them lift the tongue, not putting the fingers right into the wound, but alongside that to do the stretches that we recommend. A couple of last pictures just showing for a labial frenectomy, an adult obviously, and the simplicity of that. And then when we're talking about maxillary labial frenectomies, we do want to keep the laser beam perpendicular to the frenum. We do not want to undermine, because we're not going into the lip. We are actually, you know, approaching the frenum from the incisive, you know, just in front of the incisive papilla and between the teeth and going upwards now. So it's kind of opposite to what we saw in the tongue, but we're going up not into the lip, but stopping at that line or thereabouts to create the new attachment area. We're purposely telling it where we are wanting it to attach. And we made it.